Modern medicine relies on a collaborative partnership. However, when a healthcare system prioritizes policing a patient's character over their biology, that collaboration disappears. In the Stanford Prison Experiment, assigning healthy participants the roles of guard and prisoner generated authoritarian abuse. Electronic medical records act as a modern role-sorting mechanism, placing doctors and patients into rigid hierarchies before they ever meet. Once the software assigns these roles, the focus of the medical encounter changes. Objective biological care is frequently sidelined in favor of behavioral management and control. Systemic dehumanization begins when a provider, trying to limit their own professional liability, adds a subjective, stigmatizing note to a patient's chart. This diagram shows how labels like drug seeking function as clinical alerts that carry more weight than actual lab results.
Like prison uniforms, these tags strip away individual identity and replace it with a single permanent administrative category. From the moment that category is saved, the institution views the person through a punitive lens. The patient's physical symptoms are now secondary to the behavioral fiction created by the record. Because of how hospital networks are built, these labels travel automatically. Through a process called auto-migration, a single subjective comment from one clinic visit becomes a permanent part of the data that follows the patient across the entire healthcare system. This creates an immediate perception shift for every future provider. When a specialist opens the file, they are greeted by a high-level severity warning before they have even seen the patient's name. This algorithmic warning acts as a psychological trigger. It places the doctor on the defensive, subconsciously casting them in the role of the skeptical guard before the appointment even begins. The doctor's focus shifts from investigating symptoms to auditing the patient's words. They search for inconsistencies that might prove the difficult label correct, rather than listening to the patient's reports of pain or illness. The software itself ensures that the provider views the person as a hostile manipulator before they speak a single word. A labeled patient is often penalized for their own knowledge. If a person with a chronic condition like multiple sclerosis understands their specific medication dosages and half-lives, they are often flagged as suspicious. Providers are frequently trained to interpret this precise self-advocacy as a sign of drug-seeking behavior, rather than a high level of health literacy required to manage a complex illness. This chart demonstrates diagnostic overshadowing. When a labeled patient arrives with a physical emergency, like a kidney infection, the symptom is filtered through their mental health history. The physical crisis is redirected and documented as a behavioral cry for attention. This forces the patient to perform an unnatural level of emotional stability and compliance. They must remain perfectly calm while being denied care, simply to avoid confirming the combative label in their chart. The record creates a situation where the very act of seeking medical help is documented as evidence of a personality disorder. To test compliance or adaptability, providers may abruptly remove stabilizing medications the patient has relied on for years to manage neurological conditions or pain. This intervention leads to a predictable biological outcome: severe physical withdrawal, profound sleep deprivation, and acute physiological panic. When the patient experiences this system-induced biological collapse, the resulting distress is documented as emotional dysregulation or limit-pushing behavior. This completes a circular logic loop. The system uses the biological suffering caused by its own clinical choices as the final proof that the patient's original, stigmatizing label was accurate. In these moments, the medical encounter perfectly mirrors the abusive dynamics of the Stanford experiment, where guards use the prisoner's distress to justify further control. Labeled patients often become untouchable, trapped in a ping-pong effect, where different departments bounce the patient back and forth through referral loops to avoid the liability of treating a complex case. This visualization shows the institutional circle of protection. Providers often prioritize protecting a colleague's previous diagnosis, even an inaccurate one, over investigating a patient's current medical emergency. For many providers, the perceived risk of treating a difficult patient outweighs the risk of doing nothing. Clinical inertia becomes the safest professional path, even if it leaves the patient in danger. Modern medical institutions are often architected to manage administrative and legal risks, which can come at the direct expense of healing the sick. For survivors of trauma, this systemic experience is especially damaging. The demand for blind compliance and the dismissal of physical reality mirror the coercive control they may have escaped in the past. When the healthcare system forces a patient into a state of total helplessness, it stops functioning as a place of healing and becomes a source of further injury. Medical chart labels are powerful structural tools. They dictate how human beings are treated and can effectively remove empathy from the clinical environment. Until we address this punitive metadata, patients will remain trapped in a system that values labels more than human lives.